I want to introduce Dr. Khanna. He went to training at the University of Alabama at Birmingham, and I have a special fondness for that because I worked there for quite a while. He has been practicing for 32 years. He has done over 10,000 interventional procedures. He has multiple patents that he's worked on with different technologies to help treat cardiovascular disease. And he's married to an amazing lady, Mrs. Monica Khanna. So with that, I'll introduce Dr. Khanna to talk about complex percutaneous interventions.
Thank you, Scott. So, good morning and welcome. Thank you for being here and giving us the opportunity to share what we're doing at Eisenhower with you. No relevant financial disclosures. I'm going to just start with a little case study. Let's see if I can go. I guess this only goes forward. So I'm sure all of you are aware, and somebody's already spoken to this, cardiovascular disease, heart disease itself is still the largest and #1 cause of death in our country. 22% of death that occurs in the United States is because of heart disease. And the vast majority of it is related to blocked arteries in the heart, coronary disease. So as our population, as our demographics change and we get older patients, the traditional methods of treating multiple blocked arteries with bypass surgery become more difficult to manage, right? And so this is one of the things that we're going to talk about, how our demographic, particularly where we practice, where we live, is changing, and how our older patients we manage now without doing excessively invasive or more invasive procedures so that we can get them to recover quickly. This is a case study of a patient. This is an 89-year-old patient, and I'm just going to run through these pictures. These are pictures of the heart, the arteries of the heart in the patient. And you will see there's a blockage in this artery. This is the artery on the right side of the heart, the right coronary artery. You've got a blockage there, another one there. And then you come over to the left side, and the main artery, the left main artery itself, is about 80% blocked. You can sort of see it's almost pinched over there. The artery on the front wall of the heart, what's called the widowmaker, has a 99% blockage right there. And then the circumflex, which fills the side wall of the heart, has multiple areas of plaque and blockage. This plaque is not just soft plaque, it is hardened plaque, it is calcified. This is almost like marble, like bone, not the kind of plaque that you can easily treat with expanding with a balloon. And then this patient is elderly, our surgeons do a wonderful job, and if you showed them one of these cases, they can do the bypass surgery. They will actually bring the patient through the bypass and be fine. The problem is you now have an 89-year-old that has to recover from a large midline chest incision, open chest surgery. And that's where we run into trouble. The patients come through the surgery, but the recovery is very, very difficult. It's entirely different if you're operating on somebody that's 60 or 65 years old. They have a lot more reserve and a lot more ability to heal and bounce back. So those are the things that we are dealing with from a level of how do we treat our patients. And we have this heart team approach at our institution that works really well. So when we get a case like this, everybody sits down, everybody looks at the patient. The patient is seen by the cardiac surgeons, their PAs. The patient is seen by us. The general cardiologists oftentimes will see them first, and then I'll be asked to see them after they've had the angiogram. We put our heads together and go, well, what are the risks of actually operating on a patient like this? And is this patient better off being treated without opening their chest? And how do we go about doing that? So we started this journey somewhere in 2009 when a device called an Impella became available. And Impella is a left ventricular assist device. And what this device does is we actually position it from the leg into the cavity of the heart, and it has a centrifugal pump that spins, and it picks up blood from the cavity of the heart and pushes it into the aorta. And the aorta is where these arteries originate and run on top of the heart to supply blood to the heart. What that means is even if the heart muscle is not working, if the heart stops pumping, I can continue to work in these arteries, okay? So that becomes critically important. And so I'll explain also to you what we're talking about here. So here are the arteries. You can see they're severely blocked, right? And what we did with this patient is we put an Impella in. I'll give you a little physiology introduction as well. So if you think about blood flow in an artery, what drives blood flow in this artery? You have to have high pressure at the beginning of the artery and low pressure at the bottom of the artery. So that's what drives flow. When the heart pumps and the valve closes, you have what's called the diastolic pressure. That's the lower number in your blood pressure. So if your lower number usually is 60, 70, and the pressure inside the heart cavity is somewhere between 10 and 12, what we call the end diastolic pressure. So you now have 50 or 60 millimeters of pressure that is driving this flow in this artery, okay? What happens when you put a balloon or a device into the artery to try and expand it, to open it, is there's no blood flow in this artery, and the heart muscle starts to get stiff. And the pressure inside the cavity of the heart goes from 10 to 20 to 30 to 40, depending on how long you've kept that balloon up or how long you've impeded flow. If you are dealing with one artery, it's usually not an issue. If you've got 3 arteries that are blocked severely and you block one completely, this patient can collapse on the patient, on the table. So you have immediate hemodynamic collapse, meaning the blood pressure goes from 140 to 40 in a matter of 30 seconds. And the heart becomes stunned and does not squeeze properly and does not come back no matter what medicines you're pushing to get the blood pressure back up. So this happens in a matter of 30 seconds to a minute. This is not something that's taking 30 minutes to happen. This is why when we're doing angioplasties, we're doing stents, we are constantly watching what the patient's blood pressure is, what their oxygen levels is, what their ECG is doing. All of this is continuously going. So as we work, there are about 6 variables that all of us are looking at any one time. Any indication that the patient is beginning to deteriorate, you have to deflate your balloon and bring it out, okay? Get it out of the artery, restore flow again. So this is what we're dealing with. And that flow, that gradient of 50 millimeters or 60 millimeters that drives blood, your flow in a tube is determined by a simple mechanical formula called Poiseuille's formula. And the flow in an artery is not just the gradient, but it's the 4th power of the gradient, okay? So it's 50 to the power of 4. If I take 50 to the power of 4 and I compare it to 30 to the power of 4, I have dramatically decreased the flow in an artery. And that's why it becomes critically important to keep these patients hemodynamically stable, meaning keeping their top number adequate to keep flow going in the artery while you're working. And that's what this Impella device actually allows us to do. So this is the same patient. What we did here was we actually did balloon angioplasty and put 2 stents in. There's a stent here and a stent here, and this artery was fixed. This device here, you can see this little pigtail and this pump over here. This is the Impella pump. So this is actually sitting in the cavity of the heart, and it's pumping blood from the cavity of the heart up into the aorta. So the aortic valve sits here, and the aorta starts about here, and this is where the origin of this artery is, just above the aortic valve, right? On the left side in this patient, that plaque that he had was so hardened and so calcified that if I had put a balloon in and tried to expand it with a balloon, that artery would have shattered, would have perforated, and we would have had a big problem, right? So what we do in a patient like that is we use a device called a rotablator, a rotational atherectomy device. And what this is a little football-shaped device that is covered with industrial diamonds. It starts in a smaller size at 1.25 millimeters in diameter, and the largest ones are up to 2 to 2.5 millimeters in diameter, right? So what we do is we put a very thin wire down the artery, and you can sort of see the end of my wire here. This wire is 10/10,000ths of an inch. So it's about the thickness of a human hair, right? We thread this past all the blockages into the artery, and then we run our device over this wire using it as a rail system. Okay? Now, when we're spinning this, what we're doing is we're fragmenting the plaque into tiny particles. That plaque, the particle size is smaller than blood cells, and it washes through the heart muscle itself. It goes into the venous system, and it gets taken up by the immune cells of the body. When you're doing this, you have to be careful. If you try and go too fast, what happens is you get so much sludge in the artery itself, the blood flow shuts down altogether. So while we're watching the hemodynamics, the blood pressure, the heart rate, the oxygen levels of the patient, you're driving this device down the artery on a heart that's moving 60 to 80 times a minute, and you're trying to do this by touch and feel, right? So what we do is we ream the artery out, get all the hardened plaque out, we put a balloon in and we expand the artery. And now you can see over here, we've expanded this artery with a balloon after it's been reamed out. And these balloons that we use are tiny catheters. They're about, if you held the shaft of the balloon in your hand, it's about the size of a very thin pencil lead. But we can get pressures inside these balloons up to 20 atmospheres, okay? 20 atmospheres is 10 times the pressure inside your car tire, okay? So that's the kind of pressure we're using to expand this plaque and stents. There are newer balloons that actually have a lithoplasty application, and what that is it delivers sound waves through the balloon like you would use to smash kidney stones. And with this balloon, we can put this balloon into the artery where it's hardened and calcified. We can expand this balloon and we can deliver 80 atmospheres. So we're talking 40 times the pressure inside your car tire, right? And this is delivered in shocks. It's called shockwave lithotripsy. So there's newer and better technology coming that allows us to do all of this. So here's the artery. We're sort of doing a rebuild job, and you can see the artery that was severely blocked here. This is all fixed now. I've got stents going from here all the way down to here. I've got this area opened up. I've got this area to work on still. And then we get this area treated with a rotablator, and we put a stent down here. So what I've done with this patient is I've done a complete reconstruction of his heart circulation, right? This has taken 7 stents. This was a 3-hour case. The entire time, the patient is actually given mild sedation, and I can talk to them while I'm doing this, right? They're not under general anesthesia. They're comfortable in a little bit of a twilight state, but we actually want that to happen because we actually get feedback from the patient. If the patient tells me they're having ongoing chest pain while I'm working, that's not a good thing. If I hear, oh, I can't breathe, that's not a good thing. Those are indicators to me that actually help me change what I'm doing, right? So this is sort of it's a very different environment in the operating room where I work versus a traditional operating room where a patient is under general anesthesia, asleep, and the surgeon is operating. There's no interaction there. I actually like having that feedback because it helps me know that the patient is doing well, right? And here's part of the circulation now, the left main, the left anterior descending. We've sort of rebuilt this entire circulation, and we've gotten this guy taken care of. Our pump that we put in, the Impella pump, comes out after this procedure is finished. The patient leaves our operating room talking, halfway sitting up on a gurney, with no lines, completely stable, right? So there is a way to completely open up arteries that are blocked, and this is something that we are doing more and more of. Why? Because we have patients who are in their mid-80s, late 80s, they have lung problems, they have kidney problems. If you open their chest and did the bypass, well, the bypasses were working, the operation went smoothly, but your patient is not doing well post-operatively. You can't get them off the ventilator because their lungs were bad, their kidneys are going into failure because they went through such a big operation. So all these things have to be factored in, right? So this is the Impella device, and what it allows us to do is it allows us to treat high-risk patients. We can do what's called complete revascularization, meaning we can get all the arteries that are blocked opened up. And we can do this oftentimes at one go. So we take care of all the blocked arteries and the patient's not having to come back to fix another blocked artery at a later date. This is something that we routinely do in patients who have multiple vessels and are not good candidates for bypass surgery. We know that the overall heart muscle function in these patients will improve after we've restored their circulation. So a lot of these people have what's called a depressed or low left ventricular ejection fraction. Once you reestablish the circulation to the heart, the pumping function of the heart muscle actually improves. And we will see that improvement oftentimes immediately, but it takes sometimes as much as 6 to 8 weeks to see how much improvement you're getting. And the way I sort of like to describe that is that if you had an atrophied muscle from disuse, meaning you hadn't used your arm and your muscles were really weak, your grip strength might be very weak, but if you worked at it every day, well, 4 weeks later, 6 weeks later, your grip strength is going to be a lot better. And it's the same thing with the heart. The heart muscle improves over a period of time, right? What this has also allowed us to do is it has allowed us to do this with a lower incidence of AKI. And what is AKI? It is acute kidney injury. When we are doing these procedures, we have to give iodinated contrast into the arteries. Every time I pass a rotoblader, every time I expand a balloon, I have to take a little picture to make sure that I've got good blood flow. I haven't got a perforation in the artery. So during the case, a case like this, it's not unusual for us to take 25, 30 pictures, and each time you take a picture, you're injecting iodine, right? The more iodine you give, the higher the risk of damaging the kidneys, because iodine can be toxic to the kidneys, right? When you use an Impella device, what you're doing is the cardiac output never diminishes. So your other organs, which your body normally would not perfuse because it's trying to keep the blood for the heart and the brain, the other organs in the body, including the kidney, continue to get good perfusion. So you actually decrease the risk of kidney injury when you're using one of these devices. All right. It also results, obviously, in shorter hospital stays. If you end up fixing a patient like this, they're in overnight, they go home the next day. They walk out of the hospital, right? It's unlike a open heart surgery where you're in the ICU for maybe 2 days, 3 days, you go upstairs, and then day 5 or day 6 or day 7, you're going home, right? It's entirely different. And this basically allows us to provide treatment options for patients that are not good surgical candidates. The Impella device is actually the only hemodynamic support device that is proven to be safe and effective in elective and urgent high-risk PCI. PCI is primary coronary intervention. So what's happening with Impella is that we are actually significantly decreasing what we call MACE. That's major adverse cardiovascular events. And that's death, myocardial infarction, stroke, and the need for repeat intervention on an artery, okay? That decrease is as high as 29% in this group of patients. When we compare what we can do for a patient with an Impella versus without an Impella, when you follow these patients out 30 days and 90 days, this is what you find. Obviously, you see patients who have a better quality of life because they're not having to heal from a big operation. When I get done with one of these Impella cases, usually there's 2 incisions and 1 in each groin that's about the size of my fingernail, right? That's what the patient's going home with. A little different than an open heart surgery incision. On the average, patients are in the hospital 2 days less, and there is 52% decrease in readmission rates when this device is used. So the patients benefit. Fully 22% of patients will have an increase in their left ventricular ejection fraction. That's the pumping capability of the heart. There is a 58% incidence of decrease in the class of heart failure. So there's, when we talk about heart failure, we're talking about, I'm sure Dr. Patel has already spoken to this, patients who are short of breath, who can't get enough air, class 3, class 4. Class 4 patients are who are short of breath at rest. So you have a significant movement from the class 3, class 4 down to class 2 and class 1 in these patients. A significant improvement. That improvement happens almost instantaneously, within a matter of 2 or 3 days, not months, right? You decrease the risk of out-of-hospital MACE, and you decrease the risk of kidney injury for patients. What it does for us as physicians is it actually allows us to work in those arteries for longer periods of time. Now, if you're blocking an artery with a rotablator and you're trying to clean the plaque out, if you don't have support in this patient that's doing the work of the heart, what you're going to do is you're going to sludge the flow of blood in that artery. And when you do that, the heart muscle becomes stunned and the blood pressure begins to drop, right? And now you're scrambling because you got to get your equipment out and restore blood flow. So this device will actually allow you to stand there, take your time, and easily get the area cleaned out. You make some passes, get a little of the plaque out, let the blood flow through, bring your device out, wait 20 seconds, 30 seconds, go back in, do it again. And sometimes we'll stand there and we will rotablate an artery for 20 minutes, for 30 minutes to get the plaque out, right? And it's very much dependent on the patient and the artery and the presentation of the patient. So this device actually allows us to do that with much more ease. And there's a fully 50% decrease in the event of hypotensive events. When hypotensive events are a bad thing in my operating room, that means the patient's blood pressure dropped. Okay? That's when we're all scrambling. And as the operator, as the physician, this is where you're giving orders to your nurses. Okay, give me some epinephrine, give me this, give me that, right? Push this, let's get this up, give me some fluids. And there's a cadence that and a stress level that begins to rise when these events happen. Well, if I can decrease that by 50%, it's good for me, it's good for my staff, and it's really good for the patient. So this has actually increased our ability to do these procedures. There are more than 121,000 patients per year now that are being treated that otherwise could not have been treated because of this device nationwide. And there's actually great support. The company provides good support for this device as well. There's a 50% decrease in readmission rates and a 22% decrease in hospital days. Who are these patients? Right. So I have this approach to patients who have heart failure. From my approach is that if a patient has heart failure, they should have an angiogram. Why? Because one of the frequent causes of heart failure is blocked arteries, right? If you did a stress test and your stress test looked normal and you had heart failure, you'd say, well, that patient doesn't have blocked arteries. Not true. Your stress test will pick up patients that either had no blockages, and you'd be right in that instance, or you have patients whose arteries are so severely blocked that there's no disparity in blood flow between the left side and the right side. So you can have a completely normal stress test, you can have a normal left ventricular ejection fraction, and you have congestive heart failure, and you have triple vessel or left main disease that doesn't show up on a nuclear stress test. So as a matter of principle, if I see a patient who's had heart failure and they have not had an angiogram, I will do an angiogram, right? And why is that? Because in our country, this is what the demographics are. There's 1.7 million patients who have class 3 or class 4 heart failure, right? And every year you add about 250,000 people to this group. New diagnosis of heart failure. Almost 70% of these patients have coronary artery disease. They have blocked arteries. And if there's any chance you're missing a reversible cause, and it takes literally 10 or 15 minutes to do an angiogram, and we go through the risks, so the morbidity from it is so little, that this is a test that I think has to be done in every patient that has heart failure. 60% of these patients will have a reduced ejection fraction. And when you do their angiograms, you find that 55% of them actually have good targets to do bypass surgery. But fully 2/3 of them are not candidates for bypass surgery for other reasons. Age, frailty, lung disease, kidney problems, all kinds of issues that make patients poor candidates to have open heart surgery. So when you look at this, the patients who have hemodynamic compromise, who have complex coronary disease, all of this, there's about 120,000 patients nationwide that are getting this procedure now. Okay? We did our first Impella case here in 2009. That was the year it was approved by the FDA. And we actually, I think, did it within a few months of the approval. When you look at these patients who have triple vessel disease that are not surgical candidates, they have a 6 times higher increase in hospital mortality, right? So you're talking about the sickest of the sick cardiac patients now. There is a 22% of these patients, this is one of the clinical trials where they had data on these patients, had either left main or multi-vessel coronary disease. Okay, and these patients were CABG ineligible. If you looked at patients with a high syntax score, the syntax was a mechanism of quantifying the severity of blockages in a patient's arteries. The higher your score, the more blockages you had. And it involved things like, was the blockage hardened plaque? Was the blockage involving a bifurcating artery? Because all those things make getting those arteries more complicated, getting them open more complicated and more difficult. And even doing bypass becomes more difficult if they're calcified or hardened. So in these patients who had high syntax scores, the all-cause mortality was 3 times higher, right? So you're talking about very sick patients now. And then the other thing that became apparent is that if you could safely get the arteries opened up in one setting, those patients actually did better, rather than fixing 1 or 2 arteries and then bringing the patient back to fix the 3rd artery, right? So this is the Society of Cardiovascular Angiography and Interventions, and this is our society that all of us that do valves, that do blocked arteries in the heart, we all belong to this. This is our where we have our annual meetings, where thought leaders come forward with new ideas, with new clinical trials. Their guidelines talk about complete revascularization and how it's associated with better outcomes. All right, there's a 71% at 1 year, a 71% risk reduction in all-cause death, a 27% risk reduction in major adverse cardiovascular events. That's death, myocardial infarction, stroke, and the need for repeat revascularization, right? And 41% reduction in a recurrent myocardial infarction. At 3 years, you see a 26% risk reduction in cardiovascular death and MI, and almost a 50% decrease in death, MI, and the need for another angioplasty or stent. All right. So when you look at 11 high-risk STEMI studies, 29% risk reduction in cardiovascular death and MI. And so what happens to these patients with their heart muscle? If you look at them, there is a 22% improvement in their overall pumping capability of the heart muscle. See, this is why when you have patients who have severe heart failure, class 3, class 4 heart failure, you move them over to this side, where you had only 7% of patients that had multivessel coronary disease that were class 1. After you have treated their blocked arteries with the help of this device, almost 40%, or a little more than 40% of them are now fully functional, class 1, right? And even the sickest patients, the class 3, the class 4, you've significantly impacted. So not just a quality of life, but you're talking longevity as well, right? Skip this slide. So what do we look at when we are considering whether we need to use this device in a patient, right? So this is sort of our checklist. First, is the patient hemodynamically unstable, right? So if somebody calls me from the emergency room, I've got somebody having a heart attack, the first thing I want to know is what are their vitals? If the patient's blood pressure is in the 70s, my crew already knows that the Impella has to be ready. If that patient's coming in with a blood pressure of 120 over 70 and their heart rate 60 and their oxygen levels are 99%, we're good. The device is still parked in the corner of the room, but it's not, we're not breaking the packages open right away. So that becomes really important. Does the patient lack the reserve to sustain a brief ischemic insult? And what that is what I talked to earlier. Ischemia is lack of blood supply. And if I inflate a balloon in an artery, there's no blood flowing in that artery. If the other two major arteries in the patient's heart are nice and open and there's flow in those arteries, that patient will tolerate a balloon inflation for 30 seconds, 60 seconds, and will be okay. If the other arteries are 90, 95% blocked and you do this, you've got probably about 10 seconds to get in and get out. You take much longer than that, that's where you have hemodynamic compromise, right? But if you put an Impella patient in that patient before you go to work, well, that will allow you to do the longer inflations. It will allow you to do the rotobladers. So those are the kinds of things that we look at, right? So is the patient at risk for complete interruption of blood supply that will lead to hemodynamic collapse? What I was just talking about, same thing. And is the patient at risk for prolonged ischemic insult? So once these patients start spiraling and going down, it gets very difficult to get things turned around. And there's actually data to show this, that if you decide you're going to do an Impella in the middle of a case when things are not going well, you will have much poorer outcomes than if you decide up front that you're going to use the device, right? Because those 3 minutes or 4 minutes that you lose while you're putting the Impella in can result in a bad outcome. Right? So those are the sorts of decisions that we're making based on our evaluation of the patient. So here's a case example. This graph over here sort of reflects what the patient's blood pressure is doing, right? So, and we're talking, this is a 66-year-old patient, so relatively young by our standards, got a bypass graft that has an 85% blockage in it. It's the only bypass that's still open. So this patient has a diminished heart muscle capacity, only one bypass, which is severely blocked, an ejection fraction of 30%. Well, what happens to this patient? When you inflate a balloon, this is your mean arterial pressure, right? You started out with a mean arterial pressure of 110. In 15 seconds, this patient's mean arterial pressure is down to 50. In 30 seconds, you're here. At 45 seconds, your mean arterial blood pressure is 42. And I've seen enough of this that I can tell you that if you're here, you're going to lose this patient on the table, right? I'm sorry. So you want to keep it 65 and above, right? You want to keep it 65 and above. You put an Impella in this patient, and this is what happens. You get a decrement, you get a decrease, but you never get down into danger territory. So it allows you to work much more safely. And here is the actual hemodynamic tracing of a patient like this. So this up here, this red line, this jagged red line is your arterial pressure tracing. This white line is your pressure tracing inside the cavity of the heart, right? So this red line is showing you perfusion, meaning what's coming out of the heart. And this white line is showing you what's happening inside the cavity of the heart. When you inflate a balloon, this is what happens. Look at the pulsatility over here. See this red line? It starts to lose its jagged character and it starts becoming flat. And right here, it is completely flat. What this means is the heart has actually stopped. But with an Impella device, what you're seeing over here is now getting delivered to the brain and the rest of the body. So I don't even have to stop working when the heart has stopped. I can continue putting my stents and balloons in. And the patient is still talking to me. They're still getting perfusion to their kidneys. Their lungs are still oxygenating adequately, right? So that's what an Impella allows me to do. Now, when I deflate the balloon and the blood flow in the artery is restored, you start seeing the pulsatility coming back. You see how this jagged up and down flow comes back in the aorta of the patient, right? So that's what our Impella allows us to do. It also decreases the risk of acute kidney injury, what's called AKI. The high-risk PCI, if you're doing an intervention on 2 arteries and 3 arteries, if you're using rotoblator, that increases the amount of iodine, amount of contrast that you're going to use in these patients. And because the heart muscle itself is getting stunned while you're working, the blood flow is directed to more vital organs, to the heart itself, to the brain, and the body has this defense mechanism of pulling blood away from non-vital organs, from your gut, from the kidneys. Well, if you're doing a procedure over 2 hours and 3 hours, and there's less perfusion to the kidney, less blood flow to the kidney, you're more likely, and you are giving iodine, which is toxic to the kidneys, you're more likely to end up with kidney injury, right? So this device actually decreases the risk of that happening. It decreases the risk of dialysis. It decreases the risk of acute kidney injury. And this is a graphic representation of what we just talked about. Any kidney injury, if you're using Impella, is at 5.2%. And if you're not using an Impella, it can be as high as 27%. Right? And there are different ways to measure kidney injury. This is an increase in serum creatinine of more than 0.3. This is a 2 to 3-fold increase in serum creatinine. You can see that happens in up to 12% of patients when you do multivessel intervention without support. And the need for dialysis. Where you're using Impella, the risk is less than 1%. It may be as high as 6% in patients when you're not using an Impella device. And this is just a risk stratification. You have patients who are in cardiogenic shock, who are in trouble. Those patients, we tend to use the Impella at a much lower threshold. You know, we're more likely to put that in right away. So here are the characteristics of these patients that are not good candidates for bypass surgery, right? They have poor targets or poor conduits. So just not an artery that a surgeon can sew a bypass into. And you have to think about what the surgeon does. What he's taking is he's taking either an artery that's underneath your collarbone, or he's taking a vein from your leg, making a tiny incision in the artery that runs on top of the heart, and laying the opening of this vein, the circular opening of this vein, on top of that incision, and then sewing that vein into the artery itself, right? And these arteries that run on top of the heart are anywhere between 2 and 4 millimeters in diameter. Not an easy thing to do. And if that artery is full of plaque, if it's got calcium, and you can't put a needle through it easily, well, that patient, you won't be able to bypass. So those are the issues that we deal with. The heart team sits, we look at the angiogram and the pictures of the patient. We go, yeah, this patient, there's no way you're going to be able to sew the bypasses into. So we better go a different way, right? So those are the patients with poor targets. Patients who have kidney failure already, who have kidney insufficient, renal insufficiency, creatinine of 1.8, 2.0, 3.0. those patients are going to do poorly during bypass as well. Because when you're doing bypass surgery, the heart is in standstill and the body is being perfused by a heart-lung machine. The kidneys don't necessarily get the perfusion that is needed. So that patient is more likely to end up with a problem later as well. Advanced age, obviously, which we've talked about, and patients who have lung disease or patients who have a low ejection fraction. So what has happened with this device is when I started in this field 30 years ago, what used to happen was when I had the sickest patients, I'd do their angiograms and I'd call the surgeons and say, this patient needs help. There's a little bit of a role reversal happening now, because what's occurring is our patients are older, they're healthier from a standpoint of, if you compared what a 70-year-old looked like 30 years ago and what a 70-year-old looks like today, the vast majority of 70-year-olds today are healthier than they were 30 years ago, right? We've had 3 decades of no smoking and being careful about your diet and the importance of exercise, which those people didn't back then. But that's also now created a situation where we've got people that are 85 plus and 90. So the disease process is beginning to show up 20 years, 25 years later. Well, how do we approach a patient that's 90 when they've got severely blocked arteries, right? So that conversation has to happen. So now it's not infrequent that I'm having a conversation with our surgeons and they're going, yeah, we could do bypass on this patient, but the patient's 88, 89. They've got some kidney issues. They've got some lung issues. How do we approach this? So that patient is now coming back to me and I'm putting in an Impella and doing rotobladers and stents to rebuild their heart circulation. And that's what it's about. It's about having a team, and we've got a wonderful team at Eisenhower. We've got great surgeons. We've got great support in our cath lab, great nurses, great scrub staff, people that are very well qualified, very well trained, and they understand what it is that we're doing. So who are the candidates for Impella? These are candidates that are hemodynamically stable, that are high risk patients that are appropriate for revascularization. It's a heart team that approaches this decision. Impella is really the only hemodynamic support device proven and effective. It allows you to do more complete revascularization, reduction in symptoms and heart failure, improvement in left ventricular ejection fraction, and reduction for days in the hospital. Also reduction for readmissions. All right, I'm going to stop there and I'll take questions. Yes.
That Impella is not more efficient, so I don't know why we not prefer to do more Impella than open heart surgery.
That's yeah. So that's a great question. So the question was, if you're able to do so much with an Impella, and why aren't we doing more Impella and less open heart surgery? In the subgroup of older patients that are not good candidates for bypass surgery, Impella and multivessel stenting is a great option. There are certain subgroups that are still better treated with bypass surgery. So you take a patient who's diabetic and has a blocked artery, and they can get a left internal mammary artery bypass to the front wall of the heart, to the left anterior descending. That subgroup of patients does much better over a period of 10, 15, 20 years. The other thing that happens when you are doing angioplasties and stents is that we know stents have a failure rate in the 2-3% range. 97% of the time, they're fine. But when you put 7 and 8 stents in a patient and you fix 3 arteries, now you add up 3% times 3, you're looking at a 10% failure rate on a stent. So the need for another angioplasty, another stent down the road is higher versus a bypass operation. That's why this is a heart team decision. These are the things that we talk about. You sit down and you look at a patient who's 65 that needs 5 bypasses, but I can rebuild their circulation with 15 stents. Well, that's not the right decision for the patient. You don't want to do 15 stents because now your arteries are full of stents and you can never put bypasses to those stents. So you've taken that patient's option for a bypass down the road away from them. So we don't talk about what's necessarily going to get them fixed and out of the hospital for a day, a week, a year. We want to know what this patient's lifespan is going to involve, right? So if we do something today, that should give them the longest run out before something fails. So those are the kinds of things that we make decisions based on. Right. Good. Yes, sir. Oftentimes, the lithotripsy balloon itself has a certain profile to it. So, meaning it's not possible to get it across a blockage oftentimes, right? But if I bring a rotoblader in and if I can get a 10/10,000th wire across the blockage, I can bring that rotoblader into the blockage and I can just gently nudge it with the rotoblader and I can grind the plaque down. That allows me to put a balloon in there now because now I have enough space. So it's things like that. And then the shockwave lithoplasty balloon works really well if your calcium is concentric, meaning there's 360 degrees of calcium or at least 300 degrees of calcium, because when you deliver the shock wave through the balloon, the ultrasound shock wave, if it is surrounded by calcium, you're going to crack the calcium all the way around. If the calcium is just on 30 or 50% of the circumference of the artery, then half your energy is wasted and it's actually going to get reflected off of the calcium rather than impact the calcium itself. So the eccentricity of the calcium and the plaque also helps us decide whether we're going to use a rotoblader. Frequently, sometimes we can see that just by doing an angiogram. Oftentimes what we do is we put an intravascular ultrasound into the artery itself. So over the wire, we put a catheter that allows us to image on the inside of the artery that's 2 or 3 millimeters in diameter and moving 60 to 80 times a minute with the heart. And we can actually see on the inside what part of the circumference of the artery has calcium and what doesn't. Right? Okay. Yes. So the question was, how long does Impella work for? So we've had patients in whom we've had an Impella in for up to 2 weeks. Okay. And these are patients who came in with cardiogenic shock, who came in with a cardiac arrest. And what it's doing basically is it's doing the work of the heart, right? So you can keep a patient's brain, their kidneys functioning with the Impella going. This gives you 2.5 liters of cardiac output. There's an Impella 5.0 that gives you 5 liters of cardiac output, but that goes in from underneath the clavicle, right? So this is not infrequently used to stabilize a patient that's really sick, get them to a transplant center, where they are then evaluated for what's called a implantable left ventricular assist device as a bridge to heart transplant, right? So this has opened up all kinds of options for us. You get a patient that's really sick, you can stabilize them. You can keep them alive for 3 days, 5 days, a week. You can airlift them 7 days, 8 days out to a center that has the ability for a higher level of care. Yeah. Now, when we're doing patients who have severely blocked arteries and a low ejection fraction, but they're out there walking around, that patient may come in, we put the Impella in during the procedure to support them. And when the procedure is done, the device comes out. We close the groins, we put the patient in the hospital overnight, ICU oftentimes, or even up on a vascular floor telemetry bed, and they go home the next morning. Yes.
Can this procedure be used on a patient who's had previous catheter?
Yes. So the question was, can it be used on a patient that's had previous bypass surgery? And the answer is yes. Yeah. There's no contraindication in a patient who's had previous bypass. This has become a huge part of our armamentarium, right? We've had patients who have severely blocked arteries and a bad valve. And the patient is 89 years of age. So now you're talking replace a valve, put in 3 bypasses, get that patient through an open heart surgery at 89 years of age. We've had patients, we brought them in, we put the Impella in, rebuilt the heart circulation, replaced the valve, taken the pump out, and the patient comes out of the ICU with literally 2 tiny incisions in their groin, sitting up in their bed talking, and they go home the next day. So we're being able to do percutaneously what we 25, 30 years ago were doing with open heart surgery. Big game changer. Yes. Sure. Anybody else? Yes.
Doctors that are here at this hospital doing interventional stuff in the cath lab, how many of them are doing things like you're doing?
So there's 4 of us that are part of our 4 interventional cardiologists at Desert Cardiology that do this procedure, the Impella device. And we're happy to jump in and help even the cardiologists that are not doing this device. And we've done that. You've got a patient that's unstable and things are not going well. We'll get called into the cath lab. I'll go in and put the device in that stabilizes the patient and allows the operator to finish the procedure. We've done this on occasion, and a patient has come out of bypass surgery and they're not doing well. We've helped put in a device that helps stabilize them for a day or 2, get them turned around, help them recover. So it's just a team effort, and our staff in the cath lab, our nurses, our scrubs, the heart surgeons, everybody's involved. It's like if somebody's got a patient that's not doing well, you can call for help and you'll get all the help you need in a hurry. The cavalry arrives.
How big is it?
Sure. So just to put into perspective, so the question was, how big is the Impella? Can you describe it? That's why I wanted to run the little video, which didn't work in the presentation. But normally when we're doing an angioplasty or a stent, we do it from the wrist, and we use catheters, and those catheters are a little bit larger than a coffee straw. Okay, that's what we're working through. When I put an Impella in, the size of the tube that goes in the groin is about the size of my thumb. Okay, it's large. And the device itself is about yay big at the end of the catheter, and it has a spiral in it that's about 3 inches, 2.5 to 3 inches. That spiral sits inside the cavity of the heart, and it spins. And as it spins, it picks up the blood from the cavity of the heart, and there's an outlet near the end of that catheter where it gets pumped into the aorta. That's kind of how it works. And what we do when we're putting one of these in is we have the ability, the artery that it goes through is your groin artery. And that sits anything from, 1/4 of an inch to 2 inches below the surface of the skin, depending on the size of the patient and their weight and things like that. So what we do is we get into the artery with a tiny needle, put a wire in, and the first thing we do is we deliver 2 sutures into the artery itself. So the suture is going in from the outside of the artery, making a loop, and coming out to the outside of the artery around the wire that we put in. And these sutures sit on either side of our tiny incision. And when we get done and we take the Impella out, all we do is we cinch those sutures down, we push the knot down by 2 inches onto the wall of the artery, and we clip it down there, and the artery's sealed. All right, yes. Sure. So so the question is, what are the differences in complications with bypass and complications with an Impella? So with Impella, because you're putting a catheter in the aorta, there's chance of scraping plaque. There's an increased risk of stroke, and that happens with the angioplasty stents. The same thing can happen with bypass, because when bypasses are done, they cross-clamp the aorta, right? And when they cross-clamp the aorta, there's plaque that can break off, go to the head as well. So there's a risk of stroke with both. The risk of stroke with Impella is probably about the same, if maybe a little bit less. There's a risk of vascular complications with Impella, meaning you've got this large catheter sitting in the groin. That can actually result in lack of blood supply to the leg if it's occlusive. So that's something that we check for when we put the device in. We want to make sure that there's flow around the device, right? And there are patients who are very small where there isn't flow. And what we've done on occasion is actually put another tube in from this side, put a tube facing down into the leg, and we connect the tubes this way. So the patient's right leg is getting perfusion from the left leg, right? But these are things that you have to look for. Now, you leave an Impella sitting in a patient for 3 days, 5 days, 7 days, you're at risk of a clot forming over here. The clot forms, the circulation of the leg gets compromised. Because of that, you have to keep them on blood thinners. Well, if you keep them on blood thinners, you now increase the risk of their bleeding from where the Impella is put in. So we're always monitoring these things, right? The device itself sometimes can cause hemolysis. It can actually break up the blood cells because it's spinning, it's picking up the blood from the cavity of the ventricle and pumping it out. It can damage the blood cells, and you can get a drop in hemoglobin. So these patients may end up requiring transfusions. So those are the things that we're dealing with. All right, yes.
How is the Impella powered?
It's powered by electricity. It's a pump. It's a pump. The pump sits outside. Yeah. It's driven electrically. Anybody else? Yes, sorry, I didn't see that. Sure. Tell me your first question again. Oh, the improvement. So the question was, what is the improvement in ejection fraction when you use an Impella? And the second question was, what is the relationship between the engineering side and the medical side? Sure, right. So the improvement in ejection fraction is variable and different for different patients. It is determined by, one, how much damage has already happened to that heart muscle before you fix the problem, right? The muscle that's damaged irreversibly is not going to come back. But the muscle that's not functioning properly because of a lack of blood supply will come back. So in a patient that has multiple arteries that are blocked, sometimes that's difficult to determine. Overall, 22 to 25% of patients will see a significant improvement in left ventricular ejection fraction. And that bump is as much as 20%. So you can have a patient with a 30% ejection fraction, and they can go to a normal number, which is 50, 55, right? So it's very variable. It's dependent on different patients. It's not just that. It's also the very first patient that I did this procedure for had an ejection fraction of 7%. 7%. He had not slept in his bed for 5 years. He was sleeping in a recliner because he couldn't breathe. Okay? We did this procedure. We sent the patient home the next day. When I saw him in my office 2 weeks later, he said to me, he said, for the first time in 5 years, I slept in my bed. His ejection fraction had gone up to 20%. Now, 20% sounds terrible, but for him, it was a huge improvement, right? And then a month later, 2 months later, 3 months later, he got up to 40%, right? So it comes back. All right. The second part of your question was, what's the relationship between how do these things get engineered and how do they get to the hospital? So there's a whole biomedical field that does this, right? And I'm actually involved with development of some of these devices. So there are groups of engineers that work on these ideas. And not infrequently, it's either an engineer or a physician who comes up with the idea. And what you do, it starts out, I mean, couple of things that we've done have started out sitting at a bar, scratching out ideas on a napkin, right? Literally that way. And the next thing that happens is we're building a little prototype, you know, in a office, in an engineering lab. And you start to file patents, you start to work things on a model. You take them eventually into an animal. You know, I used to fly up 2-3 times a month. I'd catch the 7 a.m. flight out of Palm Springs up to Stanford and work in their animal lab all day. You've got, usually what we use are 120-pound pigs, you know, 120 to 160-pound pigs. They're under anesthesia, they're intubated, and we're working on their heart, deploying stents, using rotobladers. These are all investigational devices, right? So that's how it comes about. You go through the animal process, then you apply to the FDA to get approval to do an investigational device and safety review. That process is not something that takes days or months, it's years, right? And a lot of the new devices can actually not be used in the US even after they've gone through all the animal safety trials. So we've gone to South America, to Germany, to Italy to do our first cases with a device that we've developed. And these devices get approved in Europe and they get approved elsewhere, oftentimes 2, 3, 4 years ahead of the United States. That's not uncommon. Great. Thank you so much.